Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Okay, good afternoon. I would like to welcome Professor Uwe Platzbecker from the University Clinic of Leipzig in Germany. Uwe Platzbecker has been working with MDS as long as I can remember and has been running a lot of clinical trials, but also translational research. And I think you have at least, I remember a lot of trials also in low-risk MDS, and I think that's the main topic of today, is low risk low, and how can we use these prognostic indexes. So what do you think about using prognostic indexes in low-risk MDS? Can you sort of elaborate a bit on that?
Yeah, thank you, Kirsten. Also, I would also for this complex question, I would like to challenge you in reverse about the terminology, low risk. I mean, you know, we both know that this terminology is still coming from the old days when MDS, at least at some point, was not considered to be a cancer, maybe mild anemia, thrombocytopenia, whatever, and it was not clear what the cell of origin and also the mutational landscape, I think at this stage was not known. So I think from the old days, the MDS subtypes were differentiated into low risk or lower risk and higher risk based on their natural course of the disease. And you mentioned the scoring systems, which at the very beginning, like IPSS, were a reflection of patients who actually received only transfusions or antibiotics, sometimes growth factors. So the natural course of the disease was observed, and therefore patients were differentiated into lower risk and higher risk. Meanwhile, the recent update of the WHO classification reflected or is now reflecting much better that MDS is not renal anemia. It's now called myelodysplastic neoplasms. Still, the terminology MDS remains, but I think it's important to say that it's a cancer, sometimes very aggressive, with a median survival in higher risk patients of less than 6 months based on also recent molecular workup. So now I will try to answer your question. What is low risk and how to differentiate? I think we have the IPSSR, which I think we both now use for a couple of years, and also the IPSSR has come also has been introduced into clinical trials and also approval of agents like luspatercept, where the clinical trial was actually based on IPSSR. On the other side, the majority of the drugs we still have in MDS, like azacitidine, EPO, both are approved on the IPSS, so the old classification. And I will give you, I think, a very good example why the IPSSR is valid and is very good for prognostication, but where also the molecular workup, I think, is important with regards to maybe also treatment decisions. So, for instance, a patient with ring sideroblastic phenotype, with neutropenia 0.7, with mild thrombocytopenia, but being heavily transfusion dependent, and an SF3B1 mutation can basically will be in the box of so-called IPSSR intermediate, being eligible for luspatercept, for instance, as a second-line therapy. On the other side, the same patient, maybe also with ring sideroblastic phenotype just by morphology, but with other spliceosome mutations, and maybe also with a P53 mutation, which sometimes occurs also in ring sideroblastic phenotype patients outside SF3B1, may still be just from morphology, blood counts, and blast counts in the same box, intermediate, but the prognosis is much worse in this patient. So this is a long answer to a short question, but I think you touched base with a very complex and puzzling thing, which I think now also when talking to fellows and also to hematologists, I think they are sometimes puzzled which score to use. So I think the bottom line message is IPSSR is still a valid score and very low, and parts of intermediate, I would say, are the lower risk, where prognosis, even with supportive care, can be considered as in years, and therefore they are lower risk. But IPSSM, and I guess you come to that in a second, has challenged this a bit.
Absolutely, yeah. I think this was very thorough and nice explanation of how this can actually really change the way we see some of these low-risk diseases. So do you think we can use this also when we want to select which patients to transplant early? I mean, to transplant in the lower states. Have you any examples?
I think we can, but transplant is not like mild surgery. As you know, the intention is to replace the bone marrow and to reset the immune system, but still there is an unpredictable risk of mortality, which is in the range of 5 to 10% during the first year, irrespective whether you do everything right, you select the right donor. It's unpredictable, and therefore you again touch base in a very important thing. We have very good scores. We can select patients being lower risk by traditional tools, but now being higher risk by implementing also genetics. But we only have a couple of agents. Basically, we have one agent, this is azacitidine, and we have an approach called allogeneic stem cell transplantation, and that's it. So we don't have anything or only limited armamentarium of weapons, if I may use this word here in this context, to change the course of the disease. And I think that's the dilemma we have now. I think we should not stop to score patients, but I think we should rather work on agents which patients with, let's say, lower, higher risk may benefit and which may alter the disease course.
So also talking about these new classifications, how good are they if you go to the very early stage MDS, the CCOS, and I mean, can we use them there? Or because I think, that creates a new type of diseases that we see in our departments, and we all discussing what to do with them. Should we follow them? What should we do? And what's your opinion on that? What do you do in Leipzig?
Yeah, so the let's say IPSSR and also the IPSSM are not traditionally developed for CCAS patients. There are numerous papers, of course, on CCAS where the bottom line message basically is the number of mutations, the type of mutations, and the allelic burden, and the level of cytopenia. So very clear, I think, prognostic variables predict the disease progression. And I think, but still, there's a great variability, and many of these patients are older. So the question is, what is the workflow? What is the follow-up? I think this is still under investigation. The way we do it, at least in Leipzig, is that we look for all these variables, the type of mutations. For instance, TET, DMT3A is rather neutral from a prognosis, or mild, whereas ASXL1 or additional mutations like 2, 3, 4 predict a much higher risk to undergo or to develop MDS. So these patients, let's say with a higher risk, we follow up every 3 to 6 months, or the other ones we see maximum once a year.
Yeah, I think I would say the same. That's about what we do.
That's good to hear.
Of course, I think, what about... Now, to go a little bit back to what you talked about before, because now that we have this new classification, what do you do with all the results from before? I mean, from the clinical trials that we have, are we going to go back and try to sequence the material if we have it, and maybe reevaluate, for example, the indications for luspatercept, or or do you already have those data?
No, I mean we don't, or at least I myself don't. Doesn't have it, but what we know from already published data, for instance, Matteo Della Porta just published a paper where we were co-authoring, and we also provided some data, or a data set of patients, is that the IPSSM as a new scoring system is prognostic, irrespective of what you do. So let's say if you transplant, of course, the the patients with a high or very high do much better than if you gave azacitidine or if you basically observe the natural course of the disease. But the demarcation between these groups remains the same. So let's say there's a little upgrade with the survival curves, maybe also based on selection of age and comorbidities and so on. But the IPSSM, at least in the majority of analysis published or now presented at the ASH meeting, where there were a couple of IPSSM-based analysis retrospective, they all look the same. So the IPSSM remains valid irrespective of what you do. And I think this is also something where we could learn from. And the concept, I think the next concept should be that we are as precise, as targeted as possible, and maybe improve the prognosis of molecular defined or molecular driven subgroups of patients like IDH mutated patients, for instance, or P53 mutated patients. I think this should be the next step, because the kind of therapy we currently apply is very broad and very unselected. So therefore, I think the IPSSM is still valid across all these different unselected therapies.
Yeah. And how difficult is it to use the IPSSM? I mean, what does it take?
Well, it takes a minute at least, I would say. Of course, number one, it takes an NGS-based panel, where I think we do it in our academic center because we are very curious and we would like to learn, and so on. But would I recommend it on a broad scale for every patient? I wouldn't say so. I mean, it's also a question of resources, of course, but the question is, if you have an 81-year-old woman with a del(5q) MDS, being red blood cell transfusion dependent, I think I would go for P53 mutation analysis. But apart from this, maybe to look for FLT3, KMT2A, and all these things could be, of course, of interest. Maybe you find very small clones. But the question is, what does it change? Or does it change anything? So I think at this stage, I would recommend it for every patient being eligible for allogeneic stem cell transplantation, so every patient below the age of 70, all the patients above, where you have a clear MDS diagnosis based on genetics, cytogenetics, morphology, histology. So if everything is clear and you have a treatment option which is valid, which should work, let's say ESA or let's say luspatercept in lower risk patients. So there is, even if you know that the disease may be more aggressive or less aggressive, it doesn't change your treatment paradigm. This is, I think, the issue, and it may rather irritate or bewilder the patient who then thinks, well, I belong to the bad guys, although my blood counts are still very good. So I'm concerned now, and actually they will maybe suffer from a worse quality of life, irrespective of a treatment response, which may occur irrespective of IPSSM. So this is, I think, needs to be balanced. And also some patients want to know their prognosis, their putative prognosis, some may not. So I think before you tick mark, on the lab report that you want a 50 genes analysis, which can be done, as you know, Kirsten, within 2 seconds. And then a lot of workload is generated. Before you do that, think about it.
I think that's a very good advice. And I think that's where people have actually also come into trouble sometimes. I think particularly with also patients that do not want to know everything. And I think you need to be very clear about that before you start also, because some of the panels nowadays also have all the hereditary, the genes that are involved in hereditary myeloid cancer. So how do you handle that?
Yeah. Number one, we know now that, for instance, DDX41 is not restricted to younger patients, So this is something which can occur at the age of 70, 80, even MDS. These patients seem to have a more let's say, benign course of the disease. So how do we handle that? I mean, number one, in my country, if you go for inherited mutations, if you really do this workup, like the one I just mentioned, or GETA2 or others, you need to get a consent.
Yeah.
I mean, this is the same for you.
But don't you have it in the regular panels as well?
You are right. We just amended it. So I have to admit it's there, but still it requires consent. Yeah. Again, this is something which also has consequences for the family, for everybody. And again, if the patient got MDS at the age of 82 and before was healthy, everything was fine. So you can get MDS at the age of 82. There's nothing weird about it, and it's nothing which may cause a genetic workup of the entire family. So we counsel the patient, we counsel also with our genetic specialists, and then we draw conclusions. I think I would do a genetic workup with inherited genes in every younger patient, so below the age of 50, especially also those with -7, for instance, abnormalities, where this is a sign also of maybe inherited mutations like GETA2 or also the Fanconi. So I think a brief history is important. Cancer in the family, also cutaneous malformations or something like this.
And so also, of course, if you want to transplant, then it's...
Yes. Also the donor, then if it's a sibling donor, this would also require a workup. There are a lot of reviews now on this topic, and I think it's a very, very fascinating arena. We jumped in because there are many genetic traits and predispositions for patients, maybe more than we thought. But again, I come back to what I said before, Kirsten, I think you agreed on that. Think about the consequences for a family trait and for all the people before you tick mark this analysis. And to know that you may develop MDS in the next 20 to 25 years with a likelihood of 50%, let's say it this way. Does it really help you? And do we have any interceptive medicine at this stage? I don't think we have. And maybe you need an antidepressant pill then as an interceptive medicine, because you get so depressed that you will maybe get MDS in 20 years and you forget to live.
And that's the worst thing that can happen.
That's the worst thing which can happen, and therefore I think it requires interdisciplinary workup, interdisciplinary collaboration with people who understand the consequences, not only I think from a life prognosis perspective, but also from an emotional perspective and psychological perspective. And that's what we basically do here, or what we try to do. But I think it is a very wide open box at the moment. And if you enter it, I think you may basically sequence almost every patient at the end of the day, and also the family. And I'm not talking about resources here. This is not my subject, because I'm a doctor and I would like to help patients, but it's about consequences. And this should have some consequences, actually, when you do these advanced things and when you challenge patients in that way. Also, I think this is also a little bit of an issue with if we go to the other end of the scene, sort of if you have mutations in TET2 and you're obviously not particularly sick. I mean, if you have a sequence with TET2. So is this another group where you should be a little bit careful? I mean, because I think, we also know that can predispose to other things. And how do you inform these patients if you find, a mild anemia with a TET2 mutation? I mean, the immediate consequence for this is basically surveillance and observation, especially majority of these patients, it's just a finding by chance. So just with the workup at the GP. And then, if they have a TET mutation, well, I mean, this is definitely a clonal disease. The patient needs to know that This is not like reactive anemia, it's a clonal disease. But what I basically do is that I tell them that it's rather unpredictable when the disease may further evolve. Of course, with the TET2 mutation and the single mutation only, maybe mild anemia, the risk to undergo this disease evolution within the next 12 months into an MDS is rather unlikely, but you never know, of course, in a given patient. So I think the immediate consequence is a good relationship with the patient, is to comfort the patient, and is also to implement a strategy of surveillance with rather blood count assessment, which brings the patient into a position of comfort where he or she feels embedded into a strategy where all the risks are mitigated or are basically are predictable, and the patient feels safe and well with this strategy. I think this is the immediate consequence of such findings, rather than an interceptive approach or early EPO introduction or these kind of things. I think it's rather the psycho-oncology around this. I mean, if you measure things, if you detect things, you need to live with the consequences.
Yeah,
and I mean this not for the patient, I mean this rather for the doctor.
Yeah, that's true. It's also true. So I think one thing we didn't touch up on is the P53 mutations. And the IPSSM and how we can use this in a good way.
I think the IPSSM, one of the novelties of IPSSM was the implementation of P53, not as a standalone mutation, but given the risk of B allelic alterations or inactivations, either by mutation or by deletion. Those are the ones being associated with a very bad prognosis, whereas a patient with a standalone single exon mutation is still not a very good prognosis, but it's much better than patients with this B allelic alteration.
I think, would you use that when you choose who to transplant?
Yes, and I must tell you, I would rather. The B allelic are really the worst, and whatever you do, it doesn't work. So maybe you have expected the answer that I say I would transplant the B allelic, but I would rather say I would transplant the non-B allelic.
No, I would do that too.
Exactly.
Yeah, that's what I think. That's what our transplanters say too. It's not.
Yes. Yes. We currently have a patient here with B allelic P53 complex karyotype who had EB2 and developed AML very early thereafter, got an induction chemotherapy, did not respond, got azacitidine/decitabine. We switched because of P53, then later venetoclax, 3 cycles, did not respond, is still in a good condition, but is basically full of MDS/AML. The cells in the bone marrow, so we decided not to transplant because you will not get this patient into long-term remission. So this is, I think, we need other tools. We need maybe CAR-Ts. We need immune therapy for these patients. There are also other agents, as you know, in development. But I would, as you said before, with the B allelic, I think the only chance of potential cure, is that you induce certain level of remission before transplant, and then you go maybe you go for MRD-driven approaches after, or maintenance or whatever. A patient who has B allelic disease and is uncontrolled, still with excessive blasts before transplant, I would not go for transplant. And then there are those very rare cases with less than 5% blasts and maybe pancytopenia. So these are patients at this stage of developing higher risk MDS within the next 3 to 6 months. Those ones, I think you may transplant upfront and don't go for any prior therapy. But again, still long-term disease control can be achieved in less than 20% of patients.
Yeah. So this is really still a tough case, I guess. Good. I think we came around a lot of issues here. Is there anything else you want to add? Or? about prognosis and prognostication?
I think what I would like to add is that don't only look at the genes, also look at the patients.
Yeah, that's so important.
Because,
yeah, and maybe we actually need a new prognostication where you actually include also comorbidities and, age of the patients. And so in a way, in the future, I don't know. What do you think about immunology, actually?
yes.
Will immunology ever be part of...
This is very important. There is an initiative led by Sharam Cordasti now to bring up a work group maybe into this. I think what we need is proper and homogenized assessment of immunologic factors in MDS at diagnosis. And also we need to understand, we correlate now drug activity with mutations or blast counts or transfusion or EPO level, but we never correlate them with any immunologic marker.
No.
So this work has to be done. And then, yes, I fully agree that at the long run, there's a high chance that this may be integrated.
Yeah, I think that would be very interesting. And, the only thing that cures MDS is immunology, some sort of immunology in a transplantation, right?
Yeah.
Although we don't know exactly what it is. So, yeah. Well, I think we came around a lot of issues here. So thank you so much, Uwe, for your time. I know how busy you are. So it was really nice.
Thank you. Thanks for having me.